Hi, I'm Dr. Brian Walsh, and welcome to the WellnessFx Baseline Panel Training Program. In this particular video, we'll be looking at the lipid panel. Now, before I get started, I just want to quickly say that, again, a blood chemistry is one of the best evaluation tools that we have in practice today to really get a sense of what's going on physiologically and biochemically in today's population. But a blood chemistry becomes infinitely more valuable if you not only understand the markers and what they mean, but you understand physiologically what these markers even are in the first place, how they work, where they're synthesized, for example. And if you understand what you're really looking at in terms of these markers on a blood chemistry test, the blood chemistry becomes infinitely more valuable because you have the ability to critically evaluate and look at the story that's being told on a blood chemistry far better than most practitioners are taught or trained to do so today. So with that being said, the WellnessFx baseline lipid panel includes total cholesterol, VLDL or very low density lipoprotein, HDL or high density lipoprotein, LDL or low density lipoprotein, as well as triglycerides, apolipoprotein B, and lipoprotein a. So those are the markers we're going to look at, but now let's take a step back and look at physiologically where these lipids and proteins even come from in the first place, what their function and role is in the body, so that when we get to the end of this video and looking at what the markers actually can indicate, you'll have a much better understanding of that. So really, to talk about some of the lipids that we see on a lipid panel, we have to go as far back to briefly just talk about digestion. Now, when we consume fats in our diet, the vast majority are in the triglyceride, or now more accurately called triacylglycerol form. That yes, we consume different types of fats, sometimes we consume a little bit of cholesterol, but really the vast majority of the lipids or fats that we're consuming is in that triacylglycerol form. Now here's basically what happens. When we consume fat, very little digestion, which is the breakdown of fats or food, breakdown or digestion occurs in the mouth or the stomach. But once it reaches the first part of the small intestine called the duodenum, the chewed up fat globule at this point needs to, step one, be emulsified. Now, emulsification essentially is breaking down a fat droplet or globule into smaller fat globules. And people know about emulsification because oil and water don't mix. So for example, if you had a jar of oil and water, they would be very much separated, but you could add an emulsifying agent, something like mustard or lecithin, to that to shake it up the jar, and then you'd find that that oil was now better dispersed in the water. Reason being was that emulsifying agent broke down those fat globules into smaller fat globules so that it could disperse in the water. So step one, which is of critical importance in order to actually digest, break down, and absorb the fats that we're consuming, specifically triglycerides, we have to have bile secretion from the liver and gallbladder. Now, that's step one. So now we have emulsified fat in smaller fat globules. The second step is that the pancreas makes a very potent enzyme called pancreatic lipase, which then further breaks down essentially these smaller fat globules or triglycerides into what are free fatty acids and a monoglyceride. So let's just take a step back. A triglyceride is really three fatty acids attached to a glycerol backbone. Now that's too large to actually be absorbed into the enterocytes, which are the cells of our small intestine or gastrointestinal system. In order to absorb the triglycerides, they need to be broken down into their smaller components. And because a triglyceride, or triacylglycerol, is three fatty acids and a glycerol backbone, pancreatic lipase breaks down that triglyceride into free fatty acids and sometimes a monoglycerol, which is just a single fatty acid attached to that glycerol. So now they're small enough to be absorbed into the enterocyte. But to take a step back and to talk about triglycerides on a blood chemistry, most physicians will tell you that you can't have triglycerides too low. And I would suggest that that's not entirely true. Low triglycerides from a health perspective is maybe not necessarily too much of an issue. But why does somebody have really excessively low triglycerides? And one of the potential problems that you can pick up on a blood chemistry is that perhaps that person has a malabsorptive issue going on in their gastrointestinal system, and or they may have some kind of biliary or bile or liver issue that they're not able to synthesize or release adequate amounts of bile to break down those initial fat globules. Understand that the pancreas releases pancreatic lipase, can only break down a fat if it's first been emulsified. If it hasn't been emulsified, it can't be broken down into these free fatty acids and therefore cannot be absorbed. And these are individuals that will largely lose in their feces or bowel movements much of the fatty acids that they consume. From a health perspective, this is important because if somebody is not digesting or breaking down their fats, that means they might not be absorbing things like the polyunsaturated fatty acids, EPA and DHA, which is of critical importance for health, as well as they may not be digesting and absorbing some of their fat-soluble vitamins like vitamin A, E, D, and K. All of these things definitely contribute to health, and if anybody's coming to WellnessFx to evaluate their particular health, these individuals want to know do they have issues with EPA, DHA absorption, fat-soluble vitamins. They're looking to optimize their health. So if triglycerides are excessively low on a blood chemistry, it may be that maybe they're following a low-fat diet and they're just simply not consuming much fats in the first place. It may be that they are consuming adequate amounts of fats, but that they are not absorbing that fat because of either a biliary issue, liver synthesis, or gallbladder, maybe gallstones, maybe they've had their gallbladder removed. And if their triglycerides are low, what that indicates from a health perspective is that maybe they lack some of the very healthy fatty acids or fat-soluble vitamins. So you can see that just understanding this process, that if somebody has low triglycerides, you actually may be looking at some issue kind of upstream, if you will, that they're not actually able to digest and absorb and break down their fatty acids, which could have negative health consequences. So once the lipid's consumed, it's emulsified by bile, broken down into the smaller fatty acids or triglycerides or triacylglycerols. In the presence of pancreatic lipase, that breaks it down into free fatty acids and monoglycerides. Now it's small enough to be absorbed across the phosphobilipid membrane, and now is brought into the enterocyte. Now enterocytes are the cells found around the gastrointestinal system. So now we have free fatty acids and monoglycerides or monoglycerols inside the enterocyte. Now, these were small enough to get in. They're also small enough to slip back out. So the first thing that the gastrointestinal cells do is it repackages these back into the triglyceride form. So it's broken down in the process, in the presence of micelles, which are bile salts, is brought to the enterocyte, brought into the enterocyte, and repackaged back into triglycerides. Now that's the triglyceride digestion and absorption. Let's have a quick conversation then about the cholesterol. We do obviously consume cholesterol in our diet. However, in terms of one's total cholesterol levels, only 25%, about 20 to 25% is from an exogenous source, meaning we consume that cholesterol and that becomes our cholesterol as measured on a blood chemistry. The other 75 to 80% is endogenously synthesized, and we'll talk a little bit about how that occurs in just a second. Cholesterol is really found in two forms. It's found here in green, which is the free or unesterified form of cholesterol, and it's also found in this purple with a line called the esterified form. Now the esterified form is the storage form of cholesterol in our body. The free or unesterified form is the form that the body can actually use. Now on the enterocytes we have transport proteins that can actually help bring in only the unesterified form. It's said that about half of the cholesterol we consume is in the esterified form, meaning our body cannot absorb it as the esterified form. It's simply too large. Or the gastrointestinal system can unesterify or deesterify it for absorption. But just with that being known, that we really absorb not all of the cholesterol that we actually consume. In purple here is a protein. It's called the Niemann-Pick C1-like 1 protein. This is the transporting protein that brings unesterified cholesterol from our diet into our gastrointestinal cells. However, on the other hand, this is a very tightly regulated process. And in the presence of too much cholesterol, there's also another transport protein. It's called the ATP binding cassette transporter. In the enterocytes is number 5 and number 8. But that can actually transport, if there's too much cholesterol, from the enterocyte back out into the lumen of the gastrointestinal tract to be excreted in feces or as a bowel movement. So that's a little bit about cholesterol absorption. Now, what happens to the triglyceride and these fats once it's inside our enterocyte? We somehow need to get this to us. Remember, the free fatty acids and the monoglyceride are repackaged into triglycerides so that it doesn't slip back out into the lumen of our gastrointestinal tract. Inside the cells of our enterocyte, of the gastrointestinal tract, we have things like phospholipids, which is found surrounding most of our cells of our body. We have free or unesterified cholesterol. We have esterified cholesterol. We have triglycerides, obviously. And in red here, the cells can also synthesize proteins. Now here's what happens. All of these things inside the cells of our gastrointestinal tract package together what ends up being called a chylomicron. Now these chylomicrons are a phospholipid membrane outer layer, and then inside have an abundance of triglycerides, and we'll look at just how much they have in just a second. An abundance of triglycerides, unesterified cholesterol, esterified cholesterol, and these proteins. Now understand that these proteins are utilized primarily as a transport, that fats don't exist well in an aqueous solution. Again, oil and water don't mix. So these proteins, in part, are attached to this very, very large chylomicron to help with transportation around the body. Now these chylomicrons, once they're made in the cells of our gastrointestinal tract, is released first into our lymphatic system, but then ends up into our bloodstream. These very large chylomicrons are transporting around proteins, triglycerides, unesterified cholesterol, and esterified cholesterol, really so that as it goes around in our bloodstream, it can transfer or deposit some of these fatty acids to our skeletal muscle cells for energy production, or it can transfer them into adipocytes or fat cells for storage. After these chylomicrons, which again are really an accumulation of the triglycerides from our diet, some of the cholesterol, proteins, and some other things, transport them around the body, dropping off fatty acids as it goes for energy production in skeletal muscle, for storage in adipocytes, and then, because it's getting rid of much of the contents on the inside, ends up quite a bit smaller. At this point, it's called a chylomicron remnant. And then what happens is, eventually, these chylomicron remnants will reach the hepatocytes, which are really just cells of the liver. The liver has the ability to break down these chylomicron remnants and use what was a part of those chylomicron remnants for other things. The phospholipids can come off and can be utilized. The esterified cholesterol can become unesterified, and the unesterified cholesterol can then be converted into bile, which of course will go back into this process of helping us break down and emulsify the fats that we consume in our diet, or it can use this unesterified or free cholesterol in the synthesis of very low density lipoprotein, high density lipoprotein, which we'll talk about in the next section. So again, just as a real quick overview, we consume lipids. Most of them are triglycerides in the triacylglycerol form. The first step in digestion is the emulsification from bile, both synthesis in the liver or storage in the gallbladder. In the presence of bile, these fats are broken down into smaller fat droplets or globules, really into triglycerides, and only then can step 2, the pancreas, release pancreatic lipase to break down these triacylglycerols into free fatty acids and monoglycerols, which are now small enough to be absorbed into the cells of our gastrointestinal tract. When they're absorbed, they get repackaged quickly into triglycerides, and then the triglycerides, esterified, unesterified cholesterol, phospholipids, and proteins are all packaged together as a chylomicron, which then goes out into the lymphatic system, eventually into the bloodstream, depositing some of the contents, mostly fatty acids, into skeletal muscle for energy, into adipocytes for storage, come back into the liver as a chylomicron remnant, which is then metabolized and broken apart. All the different parts of the chylomicron are utilized for different things. Specifically, however, for the next conversation we're going to have, is the cholesterol, the free unesterified cholesterol, is used for biosynthesis and production in the liver, again, which can be recycled back to the process of digesting fatty acids, and to the synthesis of the lipoproteins that will be the discussion in the next part of our section. Since we're talking about cholesterol and the lipid panel, let's talk a little bit about the biosynthesis endogenously within all the nucleated cells of the body. Now, it's a much longer, this is an abbreviated process, but just so we have some ideas of what actually happens, within the cells of our body, what we really want is acetyl-CoA or acetyl-CoA. Acetyl-CoA comes from either the glycolytic pathway, where glucose enters into a cell, is split into 2 pyruvate molecules, and then pyruvate can become acetyl-CoA, or fatty acids can go through beta oxidation to also become acetyl-CoA. But again, this is happening inside all the nucleated cells of our body. So once we have acetyl-CoA, through a variety of different enzymatic conversions, eventually we get what's called HMG-CoA. HMG-CoA is then further converted into mevalonate by an enzyme called HMG-CoA reductase. HMG-CoA reductase is considered to be the rate-limiting enzyme for eventually cholesterol synthesis within the body. Now, statin-lowering medications, many of them are considered to be HMG-CoA reductase inhibitors, and that's because if you inhibit the activity of this enzyme, you inhibit the further downstream production, eventually, of cholesterol. But in terms of evaluating a blood chemistry, where this enzyme comes important is if somebody has high cholesterol, the question is why. If somebody has high cholesterol, one of the potential causes is the HMG-CoA reductase enzyme is upregulated in the presence of insulin. So anybody with insulin resistance, metabolic syndrome, or diabetes that still has adequate amounts of insulin will generally have elevations in cholesterol because insulin as a hormone upregulates HMG-CoA reductase. And again, put another way is the more activity of this enzyme, the more downstream production you're going to have of cholesterol. So again, this is just a really good time to take a look at the art of looking at a blood chemistry. If you see high cholesterol, the question is why? Anybody can lower it, but why was it high in the first place? And one of the possible causes is excess insulin or blood sugar dysregulation issues. If, for example, somebody has high cholesterol because of hypothyroidism, if you tell them to follow a good blood sugar regulating diet, exercise, maybe some blood sugar regulating supplements, if the cause of their high cholesterol wasn't because of insulin in the first place, you're not going to see much of a change. For example, if it was due to hypothyroidism. But if somebody has high cholesterol, again, the question is why. You can look at other elements of the blood chemistry, which is where the critical thinking takes place, and look to see, is this high cholesterol in this individual because of an upregulated HMG-CoA reductase because of insulin? So you might look at things like fasting glucose, hemoglobin A1C, insulin, or C-peptide on a blood chemistry. If any or all of those are high, chances are this person's elevated cholesterol is due to too much insulin, too much upregulation of this enzyme, and therefore when trying to lower that individual's cholesterol, targeting their blood sugar management will likely result in a lowering of their cholesterol as well. So this is the basic, very basic pathway of how cholesterol is manufactured. I should make one more quick comment. This HMG-CoA reductase enzyme also uses magnesium in order to help regulate itself. Put another way, if somebody's deficient in magnesium, which many studies suggest that a large part of our population today is, if somebody's deficient in magnesium, and some studies also suggest the other mineral manganese, that the HMG-CoA reductase enzyme doesn't regulate itself well enough. And so you may have somebody that has elevated cholesterol because they're magnesium deficient, because this enzyme isn't helping to regulate itself well enough. Let's take a quick look at now the different types of particles, the different types of lipoproteins that are found on a blood chemistry and what they really are in the first place. Now that we know how cholesterol is made, let's look at these particles, and then we'll come back to this part and discuss what different types of lipoproteins contain what types of material within them. So we just talked about basically the synthesis of cholesterol, and of course cholesterol has been vilified as what really causes cardiovascular disease, heart attacks, strokes, etc. But then we talk about things like HDL, LDL, VLDL, IDL, cholesterol. But what I find is that people don't even really know what those are in the first place. So this image I want you to really understand for this discussion as well as future discussions and when you're looking at a blood chemistry. So what we're looking at here is very, very similar to that chylomicron. A chylomicron is formed in the enterocytes and is designed really to help deposit fatty acids throughout the body. Now what we're going to talk about are what are called lipoproteins. Now remember the names of things like LDL and HDL is high density lipoprotein or low density lipoprotein, or VLDL is very low density lipoprotein. And in just a second I'll show you a chart that has the relative contents and size of each one of those lipoproteins. But understand what a lipoprotein is in the first place. As the name would imply, it's part lipid and part protein. So let's really talk about what they are. Very similar to the chylomicrons, these lipoprotein molecules, now you could pretend this is a VLDL or an LDL, it really doesn't matter, that what these are going to have are phospholipids generally on the outside, because they're hydrophilic. On the inside we'll generally have triglycerides. They will also have proteins associated with them which these proteins by themselves are referred to as an apoprotein. But when the protein is attached, and as well as it has these cholesterol molecules as well, this is a lipoprotein. Now, as you'll see in a second, the difference between VLDL, IDL, LDL, or HDL really is the size of that particular lipoprotein, as well as the contents. As you'll see in a minute, the VLDL are relatively large and have a relatively high amount of triglycerides in them, hence being low density. The low density has to do with the buoyancy of it. It also could be called high buoyancy, to be honest with you. But the lower the density, the less triglycerides it has in the middle, the smaller it generally is, and the more proteins, because they're heavier, it will be associated with it. So high density lipoprotein will be a smaller molecule or particle, and a VLDL, or very low density, will be larger. It's larger mostly because of the triglyceride content on the inside. But now here's the thing to really understand. When you look at most blood chemistries, and we'll just talk about LDL for example. When you look at a blood chemistry, it will generally say LDL. It might say LDL with a hyphen and then have the letter C, or it may say LDL cholesterol. In most of those cases, or all those cases, what they're talking about is the LDL cholesterol only. It says nothing about the size of this particle. It says nothing about how many particles there are. And here's the important point. According to one particular study, 75% of people that were admitted to the hospital for a heart attack had normal LDL cholesterol. There's a big difference between LDL cholesterol and LDL particles, or LDL number of particles, or the size of the particles. When they look at these on a chemistry, what they're really looking at is the cholesterol content of the LDL particles, of the LDL molecules. This is an LDL particle. The higher the LDL particle amount in a given individual, the higher their risk factor for cardiovascular disease. LDL cholesterol says almost nothing about one's cardiovascular risk, according to studies. They're two totally different things. In fact, in a second, I'll talk about concordant and discordant. When the LDL particle and the LDL cholesterol, which are two different markers on a blood chemistry, are concordant, meaning they're both high or they're both low, then LDL cholesterol, which is typically found on a blood chemistry, it tends to be accurate. However, in individuals, and varying studies will suggest different percentages of people that have discordance in these. Discordance means that one's high and the other's low. If that's the case, LDL cholesterol is entirely not reliable or not predictive of cardiovascular disease. So when you see LDL, that's a high density lipoprotein is what it's really talking about. It's not talking about the cholesterol unless it says high density lipoprotein or HDL cholesterol, which again is what the vast majority of blood chemistries are running today. Now the beauty of the WellnessFx baseline lipid panel is it contains a marker that we'll talk about that tells you how many LDL particles somebody has, and that is a risk factor for cardiovascular disease. The LDL cholesterol is not. It depends on the person. And here's another point. When talking about concordance or discordance, it's very common today for people with metabolic syndrome or blood sugar dysregulation to have discordance in their LDL particle versus LDL cholesterol amount. There's a lot of people with metabolic syndrome and blood sugar dysregulation, so there's a lot of people that have this discordance in the LDL particle number and the LDL cholesterol amount. When they're discordant, it is the LDL cholesterol found in a standard blood chemistry panel tells you almost nothing about one's cardiovascular risk. It's not predictive. What we'll talk about is if this is high or if this is low, can tell you about other things that may or may not be going on in the body, but it does not tell you cardiovascular risk. So when you talk about HDL, LDL, VLDL, or IDL, what you're talking about are lipoproteins. Lipoproteins are lipids and proteins put together. The VLDL, for example, is synthesized in the liver. HDL is synthesized in the liver, and that's really what's being discussed. Now, let's pretend this is a VLDL molecule, a very low density lipoprotein molecule, which is on the blood chemistry. Very low density lipoprotein molecules are synthesized by the liver, packaged in much of the same way we talked about the chylomicrons. They have various different apoproteins, which are then apolipoproteins. The VLDL molecule pretend this is a VLDL. When this leaves the liver, it does much of the same thing that the chylomicron did. Is as it goes through the bloodstream, it releases, under certain influence of various enzymes, some of its contents. If the VLDL molecule, which is the largest of the lipoproteins, starts to deliver some of its contents, it eventually shrinks. As it shrinks, it becomes what's called a VLDL remnant, otherwise known as an IDL, or intermediate density lipoprotein. So again, you have VLDL, IDL, LDL, and HDL. The liver synthesizes the VLDL molecules. These travel around the body under enzymatic function, get rid of some of their contents, mostly the fatty acids and cholesterols. And as it does so, it starts to shrink. As it starts to shrink and lose some of those triglycerides, it becomes a VLDL remnant or an IDL, intermediate density lipoprotein. Now at that point, the liver can clear out and metabolize this IDL, or it can continue to release its triglycerides primarily, and as it shrinks, then becomes an LDL particle or an LDL molecule. So this is where we get some of these things on a blood chemistry. What is a VLDL? What you're looking at is liver synthesized VLDL lipoproteins. What really is LDL? It is in part what used to be a VLDL molecule. The liver can also synthesize LDL molecules as well, which we'll talk about. But that's really what you're looking at. This is not an HDL. HDL are something that's synthesized differently by the liver, and we'll talk a little bit about that. So again, all of these lipoprotein particles or molecules have cholesterol in them. In a standard blood chemistry, what is being measured is the LDL cholesterol content of this particular particle, or all the particles. It's not measuring the amount or number of particles, nor is it measuring the size, which is important, and I'll talk about it as well. The proteins associated with this are called apoproteins prior to being attached or associated with this lipoprotein. As the apoprotein becomes part of this, then it's considered to be part of the lipoproteins, or an apolipoprotein. One of the molecules or the markers that we'll look on this particular panel is an apolipoprotein B. What we're really looking at, let's pretend it's this one. This might be apoprotein B. Then when it's attached to this lipoprotein, becomes apolipoprotein B. So an apoprotein is a protein by itself. When it's associated with a lipoprotein, that protein then is called apolipoprotein. And we'll talk about specifically the apolipoprotein B later on in this video. But I need you to understand what a lipoprotein is. And when we're talking about apolipoproteins, like apolipoprotein B or lipoprotein a, what really are they? Those are just proteins that are attached and associated, incorporated with a lipoprotein or a lipid, and that's what those really are. So when you hear apolipoprotein, that was an apoprotein that's now incorporated into this lipoprotein. What is really a lipoprotein is a number of these different products all packaged together. You have different types of lipoprotein, VLDL, IDL, LDL, and HDL. They have cholesterol in that, and that's usually what's being measured on a blood chemistry, but that in very little ways predicts cardiovascular risk. So I'll see you in the next section of this video when we talk a little bit more about these individual markers. Okay, so now that we've taken a pretty good look at what these lipoprotein particles are in the first place, let's take a look and really just compare and evaluate the different types. So here we have, going from the largest and least dense down to the smallest and most dense types of transport for cholesterol, triglycerides, or triacylglycerols that we have in the body. Again, starting at the very top are chylomicrons. Now here you can see that in nanometers, chylomicrons are by far the largest transport for these different types of lipids. In fact, the next one, the very low density lipoprotein, is quite a bit smaller, and then they get even smaller when you get down to the high density lipoproteins. So chylomicrons are very, very large. And if you notice in percentages, this is the protein content, the cholesterol content, the phospholipid content, and the triglyceride content. Chylomicrons by far are the largest, but they're the least dense. And remember, oil will tend to float on water. And the reason why chylomicrons are so low density is because they're so full of fat or triglycerides. And easily, the vast majority of these chylomicrons are fatty acids and triglycerides, which again is their primary function of going around the body and delivering fatty acids and triglycerides to the cells, the muscle tissue, and the adipocytes. And then as you go down, notice that the very low density lipoprotein, intermediate density lipoprotein, low density lipoprotein, and high density lipoprotein progressively get smaller. But the reason why they are considered to be low density or buoyant and high density, or they would sink, is because of, in part, their triglyceride content. Notice that the very low density lipoproteins has about 50% triglyceride content, whereas the high density lipoproteins has only about 4%. Also, another one to note here is the low density lipoprotein has the largest cholesterol content of any of these. And this is why originally LDL cholesterol was considered to be the bad cholesterol, because it was found in such great abundance in the LDL particles. But again, LDL cholesterol and LDL particles are two entirely different things. Another thing then to note is the protein content. As the density goes higher, they're more dense. They're more dense because they lack fat, and in general you notice that the protein content actually increases quite a bit. Until you get down to the high density lipoproteins. High density lipoproteins are pretty equally split between proteins, cholesterol content, and phospholipid. HDL particles, not the cholesterol, HDL particles have at least 75 different proteins associated with them. So they're very dense, they're very heavy, they lack the fat to keep them buoyant, and that's partly where their name comes from. So now that we understand cholesterol synthesis, lipid digestion and absorption, the difference between the particles and what a particle really is, as well as the general and relative contents of these, now we can start talking about these different markers on a blood chemistry panel. So since we're talking about a lipid panel, it stands to reason that we really should talk about atherosclerosis, or what is really the concern with some of these lipids in the first place in causing or contributing to cardiovascular disease, things like heart attacks and strokes. So here's really the current model of how atherosclerosis or calcification or plaquing of our artery walls occurs. So here is an artery, and in the artery we have a few different layers. These particular cells here are epithelial cells, otherwise in the arterial system known as the endothelial layer. Some things you may have heard about are endothelial dysfunction, for example. These endothelium are very, very small and thin cells, but they're also fairly metabolically active in making things that helps to prevent some of this stuff and clotting and coagulation from happening in the first place. But when we get some kind of damage to the endothelial lining, the inside of our arteries, what ends up happening is the body wants to repair this. And what happens is you have these LDL particles, notice I said, it's not LDL cholesterol per se, that these LDL particles tend to get into the area of endothelial dysfunction, or I should say endothelial damage. The next layer is actually a layer of muscle. It's smooth muscle. It's referred to as the tunica intima, or the tunica media, or what could be called as the subendothelial layer, because it's below this endothelium. So what happens is there's some kind of damage, rupture to the endothelial layer, and these LDL particles, and there's different sizes, which I'll mention in a minute, there's these different sizes that they go past the endothelial layer into this subendothelial layer that's referred to as, again, the tunica media, or just smooth muscle. Then what happens is similar to how metal rusts, or an apple when it's bitten into turns brown, that's oxidation. Now what happens is when these LDL particles get into the tunica media, or the subendothelial layer, they become oxidized. And the oxidation of the LDL particles and cholesterol ends up creating an immune response. The body wants to go try to clean up this now sort of inflammatory oxidation or oxidized event that's occurring. Inside the blood we have immune markers called monocytes. Now monocytes are a part of the blood chemistry. They are circulating early macrophages. So these monocytes found on the differential port of the CBC, these will go to the area of the damage that's secreting these cytokines and chemicals. And this monocyte will come and then become what's called a macrophage. Now another word for macrophage is a big eater. Now these macrophages go to this area to essentially consume, or it's called phagocytosis, to bring in and consume these oxidized LDL particles. What happens is when researchers first looked at these macrophages that were filled with these LDL particles, they had a sort of a foamy appearance. And so those become what are called foam cells. But understand that those were alive cells that become so full of these oxidized LDL particles that they end up dying. And what happens is they usually will rupture, and much of this contents then comes out, and that is what's atherosclerotic plaque. Now generally, understand that the smooth muscle layer is the first thing to develop atherosclerosis. If it's advanced, then what can happen is some of this actually ends up coming out and starts to decrease the size or the diameter of the lumen with this atherosclerotic plaque. But this really is the process that takes place. It starts with some kind of damage. LDL particles come to the area, go past the endothelial layer to the subendothelium. Macrophages, there may be some resident macrophages that were already there. If the stimulus is enough, you get chemokines that stimulate the monocytes to also come to this area, convert into macrophages, consume this really high amount of oxidized LDL, become a foam cell, and then the foam cell ruptures, and the contents, the remnants of that, ends up becoming atherosclerotic plaque. Now here's a quick comment about the size of the LDL particles. There's really two to understand. Number one, in terms of one's cardiovascular risk, there are some that will suggest that the particle size of the LDL molecules matters, because obviously the smaller the LDL particle, the greater the chance it has of actually getting past the area of the damaged endothelium, and that totally makes sense. The larger the LDL particle, the less likely that it can actually get past. And there's a lot of logic to that, and I will say, all things being equal, if there was an equal amount of LDL particles and the small dense LDL particles, the small dense, so let's say take it a step back. Let's say there's two individuals. They both have the exact same amount of LDL. One has what are called large buoyant LDL particles. The other one has small dense LDL particles. If they have everything is exactly the same, they have the same amount of LDL particles, not cholesterol, but particles, the person with the smaller dense LDL particles is at a higher risk for cardiovascular events. However, that's when talking about the actual number of particles. If somebody has too many large buoyant LDL particles, they too are at an increased risk. It's not, again, about the LDL cholesterol level. It's about the amount or the number of the LDL particles. So you can have somebody that has a low level of LDL particles or of the large dense, let's say it again. You can have two people in this time, totally different scenario. Two people, one has a low amount of the large buoyant LDL particles, and another person has a high amount of the large buoyant LDL particles. That person is at an increased risk. Despite the size, it seems that the amount of the LDL particles actually matters when it comes to cardiovascular risk, which is why it's great that the WellnessFx baseline lipid panel has one of the markers that we're going to talk about. It will tell you the LDL particle amount. So again, size does matter. Everything being equal, you'd rather have the large buoyant type. And there's a way of looking at this using the WellnessFx baseline lipid panel. But another important factor is the number of the LDL particles. The more of the LDL particles, despite the size, increases one's risk for a cardiovascular event. So now that we've looked at all this information, let's now start to take a look at some of these markers and what it means if they're high or low. So now that brings us to the part of the training to actually talk about the specific markers that are found on the baseline lipid panel of the blood chemistry. But hopefully having that discussion of the physiology and what some of these things are will help make some of these things make more sense. Now, cholesterol, again, this is total cholesterol, as well as we could put down LDL as well, because the things that will generally increase or decrease cholesterol, or the LDL cholesterol, not the LDL particle number, will tend to be the same things. So, but here's the first point. Now, understand that WellnessFx is obviously not in the business of doing any kind of diagnosis or any kind of treatment at all. If anything is significantly outside the laboratory reference range, either too high or too low, it's probably recommended that that individual goes to seek the advice of their own licensed medical doctor. What we're trying to do here is to look at the physiological shifts that may take place to really find out how we can maybe optimize these individuals' health. So, if somebody's cholesterol is above the laboratory range, there are a few reasons why. The first one that I mentioned before was hypothyroidism, but it's not just hypothyroidism, it's actually low T3, which is the active form of thyroid hormone, or triiodthyronine. Cholesterol found circulating throughout the body is metabolized and cleared via the liver, through the the biliary tract, and into the gastrointestinal tract to be excreted essentially in feces. It's been found that T3 is associated with, for example, an LDL receptor found in the liver. Now, an LDL receptor is for the LDL particles. When these LDL particles eventually make their way to the liver, if those receptors are present, the liver can then help metabolize, break down, and excrete the excess cholesterol. If thyroid hormone, or specifically T3, is low, the LDL receptors, for example, don't work as well. And then what you get is excess circulating cholesterol, not because the body's manufacturing too much, but in fact because it's not clearing it. And in this particular individual, if it's due to thyroid hormone for some reason, simply correcting that thyroid hormone imbalance will oftentimes bring the cholesterol back down into normal levels. So, and this is the art of looking at a blood chemistry. Yes, we can look at markers and say certain things about it, but the true art is looking around at the rest of the blood chemistry to see why, for example, cholesterol is elevated. So in this particular individual, if their cholesterol was high, and let's say they had high TSH, maybe high or low T4 as well as low T3, one of the reasons that they may have high cholesterol is because of lack of thyroid hormone, or adequate amounts of thyroid hormone. And a really great way to figure out if that's the case is if this person gets treated for thyroid hormone deficiency, their cholesterol may come back down to normal. If it does, then that was the likely mechanism. If it doesn't, and they corrected their thyroid hormone deficiencies, then their high cholesterol was based on something else. A second thing that can cause it we already talked about. Blood sugar dysregulation, increasing insulin, will increase or upregulate the activity of HMG-CoA reductase. HMG-CoA reductase is the rate-limiting enzyme for cholesterol synthesis within the body. If insulin is high, so will likely be cholesterol. Again, if somebody has high cholesterol, the question is why. If it's blood sugar related, you can look at fasting glucose, hemoglobin A1C, as well as insulin, and if either any of those or all three of those are elevated, then that's something that may be causing their high cholesterol. By helping manage their blood sugar levels and managing their glucose, may actually help bring cholesterol down just as a consequence of lowering insulin and decreasing the activity of the HMG-CoA reductase enzyme. WellnessFx is not in the business of diagnosing or treating, but if something, kidney disease, for example, or dysfunctional kidneys, is associated with elevations in cholesterol. Now again, if you're a practitioner and you see this on a blood chemistry, you don't want to make any recommendations except to have that person seek the assistance of their licensed medical doctor. In terms of kidney disease, if there is an issue with the kidneys on a standard blood chemistry, what you may see is an elevation in creatinine or BUN. If somebody has high cholesterol and elevated creatinine and elevated BUN, it may be due to some kind of kidney dysfunction, and again, recommending referring that individual out to their doctor may be the best thing for them. Now, dehydration needs to be mentioned for a lot of different markers on a blood chemistry. But if dehydration is present, which it is in many people today, it won't cause extreme elevations in cholesterol, but it can create some alterations in it so that it may seem a little bit high. And here's basically why and how this works. When they're looking at total cholesterol, they're looking at the content, usually milligrams per deciliter. Milligrams would be the amount of the stuff, in this case cholesterol, per volume, which would be the deciliter. So essentially what they're doing when they're running these is they need a certain volume of blood or plasma or material or whatever it may be in order to be able to standardize or actually count how much is present. So they need to have a certain deciliter amount, and in the plasma, which is mostly water, in the plasma, if for some reason somebody's dehydrated, they'll have less water in their plasma. So what will end up happening is then the lab will have to use more to get that same level that they needed in order to measure the contents of that particular sample. They'll actually have to pull more of it to get to that level, but there wasn't as much water or plasma because somebody's dehydrated, and this therefore will have the appearance of being higher when in fact, if that individual was hydrated, then it would actually be lower. I hope this concept makes sense, because there's quite a few things on a blood chemistry that can be impacted by hydration status. And there's not a lot of studies to back this up, but there are a couple that showed that if an individual or animal was fasting, was dehydrated in fasting or hydrated in fasting, they actually had different levels of their lipids. So if somebody is dehydrated and has slightly high cholesterol, again, it's not going to create large fluctuations in cholesterol, but it may be something that you're looking at, and it's certainly something that always keep in mind when looking at these. So now if somebody, we need cholesterol. Cholesterol is used in the cell membranes of all the cells of our body. It's used in steroid hormone synthesis like cortisol, testosterone, estrogen, DHEA, progesterone, pregnenolone, as well as it is used in biosynthesis. So we need a certain amount of cholesterol, and yes, cholesterol can definitely be too low. So when looking at plasma or serum cholesterol, if it's low, again, about 20% of the amount of synthesized cholesterol inside of our bodies is done by the liver. Therefore, if the liver is not working properly, that may cause a decrease in the cholesterol level found on a blood chemistry. The vast majority is synthesized by the cells, but understand that cells will often make the cholesterol for themselves. And so, for example, that cell using acetyl-CoA or acetyl-CoA will make cholesterol for its own membrane, and that may or may not actually get out into the bloodstream. So much of the cholesterol that's found in the blood is synthesized by the liver for transport to the rest of the body. So if cholesterol is low, one thing you may be looking at is liver dysfunction. How do you know? Again, look around at the rest of the blood chemistry. If albumin is low, since it's a plasma protein synthesized in the liver, then it may be a liver issue. Also BUN, blood urea nitrogen, is a compound that's created by the liver based on amino acid metabolism. If the liver is not working well, BUN may be low as well as maybe some of the liver-based enzymes, AST, ALT, and GGT. So if cholesterol is low, look at some of the other liver markers. If those seem abnormal, maybe this person's low cholesterol is actually due to that. Another big question, and I did put a question mark next to inflammation, is because the studies are somewhat conflicting on this. There are some studies that show that certain levels of inflammatory cytokines, like interleukin-6, for example, are actually associated with low levels of cholesterol. So if cholesterol is low, there really should just be a question mark in your mind. If it's not liver, for example, that it might be some kind of inflammation. And to take it beyond that is really difficult today because there's not a lot of studies to really back this up, as well as some infections have shown to both increase and decrease cholesterol. So it's hard to really say which might be going on, but it's something to consider. Also, malabsorption may definitely be an indication. Again, you might see low triglycerides in this individual, low protein, low globulin, maybe looking at the ability to digest and break down amino acids. And then lastly, this one, the etiology is not really well known, but there are a number of studies showing that anemia, low hematocrit specifically, and low hemoglobin specifically, have at times been associated with also low cholesterol. It's hard to say. There's different types of anemia. Some of the high erythropoietic type anemias, some of the thalassemias or congenital sideroblastic anemia, for example, have been associated with low cholesterol. But again, the actual etiology of this is not necessarily known. So let's take a look at a couple other markers that are found on the WellnessFx baseline lipid panel. So now we're going to talk about triglycerides, and this is also a very interesting discussion. The lipid panel is most often used for looking at one's risk of cardiovascular disease. Now, fasting triglyceride levels have really come into question as to their contribution to cardiovascular disease, as opposed to what's called postprandial. And for those of you that know about glucose, there's the glucose fasting, and there's also glucose tolerance tests. And a glucose tolerance test is taking a baseline fasting glucose level, then ingesting a certain amount of glucose, and then taking more glucose markers for a specified amount of time after the glucose load. It has been proposed in scientific research of having a triglyceride tolerance test. And the difficulty being, however, is figuring out what meal or what should actually be consumed and in what quantities in order to figure out what somebody's response is to triglycerides. In addition to the fact that carbohydrates in excess will also cause an increase in triglycerides. So it's a very interesting concept. It's basically what has been recently discovered or developed or understood is that postprandial or after a meal consumption of triglyceride levels is actually a stronger contributor to a cardiovascular event than is fasting triglycerides. However, again, what we're doing is essentially detective work. We're looking at a blood chemistry, not just for the specific markers, but to really get an idea of what's happening in this individual's body. So, if triglycerides are high for some reason, the first thing, it's the second one listed here, but the first thing that you must ask that individual is, were you fasting or not? Glucose and triglycerides are probably the most prone to alterations if an individual was not fasting. And what I've personally found is you have to ask somebody, were they fasting or not, and for how long? For example, we've had people that, completely honest, forgot, and they had a meal before they went down to get their blood drawn. And when they saw high glucose and high triglycerides, many people might jump specifically onto something like diabetes, but in fact the person forgot and had a glass of orange juice or maybe a bagel on the way to the lab or whatever it may have been and totally forgot. Also, people don't understand that fasting literally means fasting. For 12 to 14 hours before the lab test, they shouldn't have any consumption of any kind of food at all. And again, when seeing high triglycerides and high glucose, it's a very fast question, but to say, were you fasting? When was the last time you ate anything? And to ask them, did you wake up during the night and have a bite of anything? Because if they did, they technically weren't fasting anymore. And again, we've had people that did that. So if triglycerides are ever elevated, it's the first question that you have to ask. Were you actually fasting? When was the last time you ate? Did you consume anything at all from that last bite of food that you had prior to the blood draw? Then, one of the more common causes of elevated triglycerides today is glucose dysregulation, insulin resistance, metabolic syndrome, obesity, or diabetes. Now what essentially happens is, in the presence of excess glucose, the liver cannot store this as glycogen, the rest of the body cannot also store this as glycogen, so what ends up happening is it gets converted into triglycerides. And this is one of the major reasons why people that have insulin resistance get tired or sleepy after a meal, after they eat, is because the conversion of, I should say, glycolysis, breaking down glucose into using it into fuel, is a fairly easy process. Converting glucose into triglycerides and storing it as triglycerides takes more energy, and that's one of the proposed reasons why symptomatically people after a meal get tired, is because they cannot store the glucose as glycogen, they cannot utilize it, so they have to convert it and store it as triglycerides, which is an energy-dependent process and can make somebody feel tired. So the first thing to consider is triglycerides. If it's elevated, is glucose dysregulation. Again, what can you look at? If their total cholesterol is high, if the fasting glucose is high, hemoglobin A1C and or insulin are elevated, then there's a good chance that their high triglycerides are due to the fact that they have glucose dysregulation. We already mentioned this with cholesterol, but low thyroid hormone also is associated with hypertriglyceridemia or elevated triglycerides. How do you pick this up? You look at TSH, if it's elevated, if T4 is low and or T3 is low, that may be why, or at least part of why, they have high triglycerides. And similar to cholesterol, if somebody has some kind of renal disease or some kind of kidney dysfunction, that's a chance as well. I didn't write it here, but it should also be mentioned that another thing that can cause elevated triglycerides is let's just say an evening of heavy drinking or a day of heavy drinking alcohol prior to the blood draw. That if somebody consumes a fair bit of alcohol, then there's a good chance that their triglycerides may be high as a consequence of having all that alcohol in their system. Which again is just a real quick question to see if that might have been the case. So then looking at low triglycerides again. Low triglycerides from a physiological perspective are not necessarily a bad thing, but it's also not normal. We should have a certain amount of triglycerides in our bloodstream. So when you're looking at low triglycerides below normal, again, it may not have any significant negative health consequences or any kind of pathology associated with it, but it can tell you maybe some other things that are going on inside their body. One that we already mentioned was malabsorption. If for some reason, and malabsorption takes place in two areas. One is if they have biliary insufficiency, if they're not adequately making, synthesizing, or releasing bile, if they lack a gallbladder, if they've been told they have gallstones, if they tell you that when they eat fatty foods, they get some GI upset, they may have diarrhea associated with it, they may have pain in between their shoulder blades, then what you may be looking at, somebody with low triglycerides, is that they're not absorbing it. If the gallbladder and bile or biliary system is working correctly, maybe they have gastrointestinal dysfunction. They're not actually absorbing much of anything, including fatty acids or triglycerides. So if that's the case, if you see low triglycerides, it may be a time to ask a couple more questions. The other one is, are they ingesting it in the first place? the low-fat craze of the 80s and early 90s has kind of gone away a little bit. But there are definitely some people that are afraid of fat and don't eat a lot of it. If that's the case, then maybe that's why they have low triglycerides. And the last one to mention is this. I have personally seen this to be true, and there's only 1 or 2 papers to back this up. But low triglycerides are often seen in individuals with autoimmune conditions. And in fact, when we see low triglycerides, again, WellnessFx, we're not here to diagnose or treat, but if you see low triglycerides and it doesn't seem to be related to anything else, we won't actually state this to the patient that maybe you have an autoimmune condition, but it's something that we want to keep in our mind if they have a number of other sort of unrelated symptoms. There was one specific Italian paper that looked at low triglycerides in the presence of many autoimmune conditions, and again, I will say that it's something that we've seen clinically 9 times out of 10 is that somebody with a known autoimmune condition will generally have low triglycerides as well. So it's certainly something to keep in mind. So now let's quickly talk about HDL, or high density lipoprotein. Now again, there's a difference between HDL cholesterol and HDL particle numbers or amount. According to research, the HDL cholesterol may not be as protective against cardiovascular risk as the HDL particle numbers. So we'll quickly just talk about what some of these things that may contribute to high or low HDL. HDL has considered to be the good cholesterol. In recent years, however, HDL has many antioxidant, anti-inflammatory properties, it's well known, but HDL also has some very pro-inflammatory and pro-oxidant capabilities as well. For example, it's been suggested that HDL almost functions as what's called an acute phase reactant, that are things like CRP, fibrinogen, ferritin that will be elevated in the presence of acute inflammation, that HDL may do this as well and have some, and in the presence of inflammation, be a pro-inflammatory molecule itself. So really a lot more research needs to be done on HDL. So remember we talked about that chart of HDL and the different densities and the different protein amounts. HDL had the most protein of any of the other lipoproteins. And that's significant because, again, over 75 different proteins have been found to be associated with the HDL lipoprotein. Now, these proteins have a number of different benefits, a number of different effects. There's a number of different enzymes that are associated with it, antioxidant enzymes, anti-inflammatory proteins, as well as there's a lot of new research looking at HDL as being a part of the immune system, in fact. So there's not enough information, in my opinion, that's really known about HDL. The one thing that we do know is that HDL cholesterol may or may not be protective of cardiovascular disease, but rather it's the HDL particle numbers that may be, as well as the HDL particle size. Just to give you an example, the HDL, as it becomes smaller, for example, becomes more unstable and starts to lose some of these very beneficial proteins. So the particle size does matter with HDL. There's no way of really addressing HDL particle size with this panel, as well as whether it's high or low, or the cholesterol amount, or the particle number. So anyways, real quickly, HDL, a lot of people will say that you can't have an HDL that's too high. And again, looking at some of the recent studies and some of the pro-inflammatory, pro-oxidant capabilities of HDL in certain situations, I do think that there are times when HDL could be too high, that maybe it could be pro-atherogenic, for example. One of the times that you'll definitely see high HDL is somebody that excessively exercises. Now, most of us don't excessively exercise, but in the population that may be seeking the services of WellnessFx, it is very possible that you have some very serious exercises, people that do very intense exercise many times throughout the week, for example. So if you see high HDL, just consider that may be something that they're doing, or just quickly ask, what's your exercise program, how intense, how often? And the other one I will say has to do with inflammation. Now, there's not a lot of studies to back this up, and really more needs to be done, but elevated HDL, I will tell you, at least in our practice, is a marker of inflammation. And what type, it's really impossible to say, but anytime we see HDL above, say, 80, we start to consider that maybe this individual has some inflammatory processes going on, and maybe that HDL is not actually helping them, but maybe harming them. In terms of the studies that back that up, again, there are some studies that suggest that certain infections might increase HDL, but other infections might decrease HDL. So it's really hard to tell. A lot more research needs to be done. In terms of this basic panel, we'll just say that within a certain window, looking at the ratios and looking at everything else combined, if HDL is normal, let's say high normal, that's probably a good thing. If it's too low, it probably needs to be elevated. If it's too high, that maybe there's some kind of inflammation going on. Excuse me. And lastly, low HDL is pretty common to see, especially in today's society. And when you look at these things, insulin, sedentary lifestyle, and diet. Lack of exercise will typically show up as low HDL. Insulin, if there's any kind of blood sugar dysregulation that's been going on for some time, will typically show up as high LDL cholesterol and low HDL cholesterol, as well as in diet. If somebody follows a poor diet, specifically of poor fatty acids, then that will generally lower HDL as well. So really, when it comes to seeing low HDL, it's very unlikely that you will see low HDL by itself without seeing blood sugar dysregulation markers, with other abnormalities within the lipid panel, for example. If you see HDL low by itself, there may be something else going on. But simply looking at HDL, if it's low, chances are you'll start to see a pattern develop that has to do with diet, lifestyle, exercise, blood sugar regulation, maybe thyroid hormone, and those types of things as well. So HDL is a great marker in looking at the very large perspective of all these different lipids, but by itself doesn't really tell somebody about their predictive risk for cardiovascular disease or not. I should also mention, and I didn't before, the reason why HDL was thought to be the good cholesterol is because its relative size and deficiency of things like triglycerides. It was previously believed that LDL, which it does, is higher in cholesterol, higher in triglycerides, goes around the body and deposits these things, and it's in the deposition that could potentially cause problems. HDL, on the other hand, is actually known to pick up some triglycerides, fatty acids, and cholesterol from the periphery and bring it back to organs or glands like the liver, the adrenal glands, to deposit them where they may need it. And so that was why HDL was considered to be the good cholesterol, is because LDL dropped fat off and cholesterol off, and HDL picked it up to be metabolized. So that's where HDL became the good cholesterol. But as I just mentioned, it's not as simple as that. And in fact, I personally would completely get away from good and bad cholesterol because, as we saw, LDL can be bad, but it's not always bad. HDL can be very, very good, but it also can be pro-atherogenic, pro-inflammatory, and pro-oxidant as well. So I would personally get rid of the good and bad delineations of these. They're there, sort of like insulin. Is insulin good or bad? It's both. We need it, we die without it, and we don't do very well if there's too much of it. And the same is really true for many of these different basic lipoprotein molecules or particles as well. Before I move on to this next particle, I didn't mention the VLDL cholesterol. Everything that was stated for total cholesterol is true for the LDL cholesterol as well as the VLDL cholesterol. Now again, LDL cholesterol and VLDL cholesterol may give you some insight into one's cardiovascular risk, but ultimately it's not about the amount of cholesterol found in those lipoproteins, but rather it's how many of these particles there are, as well as some other things that we'll talk about in terms of ratios. So everything for the VLDL is true for the LDL as well as for the cholesterol in terms of what can cause high or low markers. But now we're going to talk about a great marker. This is apolipoprotein B. Now remember when I talked about a lipoprotein was phospholipids, triglycerides or triacylglycerols, different types of cholesterol, as well as proteins that were associated with it. Now these proteins are designed for enzymatic function, for binding to a receptor somewhere else in the body, as well as for transport. Again, lipids do not do well in an aqueous solution. They're hydrophobic. And so it needs a protein that will help transport it around the body. Now here's what the apolipoprotein really tells you. An LDL particle, every LDL particle has an ApoB protein associated with it. Or I should say this more accurately. Every time you see an apolipoprotein B, there's an LDL particle with it. So on a blood chemistry, LDL cholesterol tells you the amount of cholesterol in the LDL particles somebody has, but tells you nothing about how many LDL particles they have. Apolipoprotein B is essentially a lipoprotein particle amount. So again, apolipoprotein B, anytime you see an apolipoprotein B, it's associated with an LDL particle, meaning apolipoprotein B is directly associated or correlated or even equal to the LDL particle number in that given individual. Now that is a predictive cardiovascular risk. The more LDL particles somebody has, regardless if they're small, dense, or large, buoyant, the more the LDL particles somebody has, the more at risk they are for a cardiovascular event. So in my opinion, this apolipoprotein B is probably one of the most valuable markers on the WellnessFx baseline lipid panel in evaluating one's true cardiovascular risk than all the others. We will talk about a few of the other ratios that are valuable, but understand that the higher the apolipoprotein B, the more LDL particles they have, and the greater risk they are for cardiovascular disease. Now, in these individuals, everything always applies: regulate blood sugar and do everything that you would normally do in order to try to lower these. Good diet, exercise program, and those types of things, as well as maybe some medications or certain nutritional supplements. But this is a great marker, and to have it on a baseline panel is fantastic. Apolipoprotein B is associated, it's a 1-to-1 ratio. Every time you see an apolipoprotein B, it's associated with the LDL particle. It's not looking at LDL cholesterol, it's looking at how many LDL particles does this individual have. The higher this is, the more at risk they are of cardiovascular disease. The lower this is, the lower risk they are for cardiovascular disease. Now we're on to the last of the individual markers before we look at some of the ratios. And this marker is lipoprotein(a), otherwise known as Lp(a). Now understand, again, this is a lipoprotein, so this is really no different than the other lipoproteins that we looked at. But what is really lipoprotein(a)? Lipoprotein(a) is an LDL particle with the protein apoprotein(a). So again, apolipoprotein B is really apoprotein B with a lipoprotein. Lipoprotein(a) is an LDL particle with the protein apoprotein A. That is lipoprotein(a). Now, lipoprotein(a) is kind of an interesting marker. It's been known for some time that there's an increased risk of atherosclerosis and cardiovascular disease or cardiovascular events if somebody has elevations in Lp(a). It's also considered to be a genetic marker. And there are some things that people can do about it. But in terms of why it creates an increased risk for cardiovascular disease, again, it's not entirely understood, but there are some mechanisms that I've written down here. One is it seems that lipoprotein(a), which again is just an LDL particle with the protein apoprotein(a), shows that it can oxidize, well, basically, it gets into the subendothelium easier, it's retained more, it's oxidized more readily, and creates more of an immune response. So that by itself would suggest why lipoprotein(a) has an increased risk for cardiovascular disease. Again, when you get damage to the endothelial layer, lipoprotein(a) seems to get in easier, stay there longer, oxidize more readily, and create a greater immune response. All those things will create more atherosclerosis or atherogenesis. But in addition to that, the protein that's associated with lipoprotein(a) seems to be glycated or glycosylated more readily than the proteins with some of these other lipoproteins. Now, what glycosylation or glycation is essentially the combining of a protein and a sugar. And to be honest, it's very much like when you caramelize onions in the kitchen, that you're combining a sugar and a protein, and that protein becomes glycated. Hemoglobin A1C, for example, is glycated or glycosylated hemoglobin, which has a protein component in it. Lipoprotein(a) has a protein component of it, and it seems that it may be glycated more readily, which would also help explain why individuals with elevations in lipoprotein(a) seem to also have a familial or family history of diabetes. So that's another genetic component. And this last one here, plasminogen, is an inactive protein found in your bloodstream that converts into the active form of plasmin. Now, plasmin breaks down fibrin, it breaks down clots, it breaks down the possibility of a thrombus or an embolus. So it's a natural process to form clots. It happens in the coagulation cascade, for example. Plasminogen is something that's present to help decrease or break down the fibrin or the clots that are present. The problem is that Lp(a) seems to structurally be similar to plasminogen and will actually competitively bind to where plasminogen may normally bind to stimulate it to convert into plasmin. So again, what that means is let's say you have part of the endothelium where plasminogen would usually bind, convert into the active plasmin, and then start breaking down some of the clots. That's a normal process. But in the presence of Lp(a), it seems that it competitively binds. So if it binds into this receptor site where plasminogen normally would have bound, now plasminogen can't break down clots. And again, Elevations in lipoprotein a are associated with an increased risk of cardiovascular disease or cardiovascular events. And this is another reason why. Not only does it potentially cause more atherosclerosis, not only does it cause more oxidative stress, but it also seems to not or inhibit the breakdown of clots. And there's other mechanisms involved with this, like tissue plasminogen activator, for example. The last thing is notice here, this is not lipoprotein a, this is apoprotein A. The protein itself seems to retard or decrease the clearance of lipoprotein a itself. So, if somebody has excess amounts of this protein, apoprotein A, therefore they'll also have increased amounts of lipoprotein a, that apoprotein A helps decrease the clearance of lipoprotein a, which means that there's too much of it doing this atherogenic process, excess glycation or oxidation, as well as decreasing fibrinolysis, or the breakdown of fibrin. So lipoprotein a seems to be genetically related, seems to increase one's risk of cardiovascular events aside from any of these other markers, as well as is associated with more blood sugar dysregulation if glucose is not attempted to be tightly regulated by that particular individual. So we'll finish up this video by looking at some of the ratios of some of the markers that we already talked about. So now we're going to wrap it up with looking at some of the ratios. And again, I've already said this, but looking at blood chemistry is fairly easy. You can look at certain markers. If it's high, textbooks will tell you what to do and what it means. But really the art of a blood chemistry comes in looking at the entire picture and what the whole story is telling you. And there's a lot more information when you look at all the different markers, understanding physiology and how it relates to these markers. And again, you can glean far more information about your patient or your client than just looking at a marker-to-marker basis. And these ratios are an example of some of these. Now, the first one to consider is the cholesterol-triglyceride ratio. This is essentially looking at the amount of cholesterol they have, the amount of triglycerides they have, and you want it to be greater than a 2-to-1 ratio, meaning if somebody has a total cholesterol of 200 and triglycerides of 100, that's a 2-to-1 ratio, and that would be considered to be good. What the cholesterol-triglyceride ratio most looks at is one's blood sugar regulation. Now, on the WellnessFx baseline panel, you do have fasting glucose, insulin, and hemoglobin A1C. So, you already have a lot of really good blood sugar markers. But this is yet another indication that their blood sugar is not being regulated well. And that is because in the presence of excess glucose, again, if the body cannot store that or adequately deal with that, the liver will then convert glucose into triglycerides. And the more triglycerides one has, especially in relationship to the total cholesterol, triglycerides are the first marker that will change fairly quickly if somebody has blood sugar dysregulation. Cholesterol will increase. For example, HDL will decrease, but that's usually a little bit later, in later stage blood sugar dysregulation. So triglycerides to go up is one of the first markers you'll see go up on a blood panel, especially lipid panel, when somebody's not regulating the glucose well. So what you want to see is a 2-to-1 ratio. If, for example, it was 200 to, let's say, 150, then that's not 2-to-1 anymore. It's less than 2-to-1, and that indicates there may be a blood sugar dysregulation. If it's 1-to-1, like 200 cholesterol, 200 triglycerides, then again, what you're probably looking at, as long as they really were fasting and they didn't have a lot of alcohol the night before, is probably some kind of blood sugar dysregulation. The next one is actually conventional, and this is found on most standard blood chemistries, and this is the cholesterol-HDL ratio. And that's because HDL cholesterol, which again is not, it's not looking at the particle amount, it's looking at the amount of cholesterol within HDL particles. It is not necessarily a great marker in looking at reducing one's risk of cardiovascular disease. But the cholesterol-HDL ratio from a conventional model, assuming that the HDL cholesterol amount is helpful in preventing cardiovascular risk, which again, research has suggested that maybe it is, maybe it's not. It's the particle size that seems to be better, or the particle amount, is if the cholesterol-HDL ratio, it should be less than 3 or 3-to-1. So if somebody has a total cholesterol of 200 and HDL of 50, they have a cholesterol-HDL ratio of 4, and that is above 3.0, so that would be a potentially increased risk of cardiovascular disease. And the last one's a pretty cool marker too, because like I mentioned with that atherosclerosis model and how atherosclerosis takes place, that LDL particle size does seem to matter to some degree. So while the LDL particle size is not measured on this panel, it doesn't really need to be, because there are some pretty interesting studies showing that the triglyceride-HDL ratio is predictive of LDL particle size. In other words, if the triglyceride HDL particle size, if the triglyceride HDL ratio is less than 3.8, they are thought to have the larger, more buoyant, more protective LDL particles. The more above or greater than 3.8 it is, then the smaller, more dense LDL particle size. So again, particle size matters to some degree, not as much as the total particle amount, but you don't even really need to run the particle size even though these labs are available, because on a basic panel you have the triglyceride HDL ratio. So if, for example, somebody had total triglycerides of 200 and an HDL of 40, that would give them a triglyceride HDL ratio of 5, which is above 3.8, suggesting that this individual has more of these small, dense LDL particles than the large, buoyant ones, and are therefore at an increased risk of cardiovascular disease. So with this particular very basic panel, knowing what you now know, you can really evaluate somebody's risk for cardiovascular disease. And yes, there are even a few markers that aren't on this panel, but what you have is great. For example, if the apolipoprotein is high, that person's at risk for cardiovascular disease. That plus, for example, a triglyceride HDL ratio of less than 3.8, greater than 3.8, that is not only high LDL particle size, but also small, dense LDL particles. That person's at even greater risk than somebody with large, buoyant, but high LDL particle size, for example. So there's a lot of different markers that you can look at on here, and they all tell you really good information. I hope you found this particular module of the WellnessFx basic baseline training program valuable, and I look forward to seeing you in the next video.